So welcome to today's webinar. My name is Jan Shorrock and I'm the Executive Officer for the charity Give a Kidney. I'm very glad to have you all with us, and I can see other people might be joining us still. So a warm welcome on this Saturday morning. So today we're going to be talking about some of the latest research into non-directed donation, and we're going to be joined by Hannah Maple and Dr. Emma Massey, who will update us on two studies, one in the UK and one in the Netherlands. For those of you who might be new to Give a Kidney, just a very brief outline of our work as a charity. We're a charity registered in England and Scotland, and our focus is non-directed living donation. So that's people who donate a kidney anonymously to a stranger, and we'll talk a little bit about the terminology of that shortly. So our remit, our mission is no waiting for a transplant for want of a kidney, and we aim to raise awareness of non-directed donation, the fact that people can step forward to donate a kidney to somebody on the waiting list in the UK. We support living donors who are going through that process, because it's often it can be a very lonely process and a very long process and a very emotional process. So we offer support to those people, and we also work to advocate for positive improvements in service and input into research studies, and work very closely with NHS and transplant and some of the units in terms of improving access to living donation, raising awareness of non-directed living donation, and improving the experience for donors. I'm going to talk very briefly about the terminology. I can see a couple of people are still joining. For those of you who might be unfamiliar to it, so non-directed living donation is the term I've just used. It does mean stepping forward to donate anonymously to a stranger on the waiting list. You'll hear other terms which are synonymous with that term and used more widely elsewhere in Europe or in the past in the UK. So it's often referred to as altruistic kidney donation, anonymous kidney donation, or unspecified kidney donation. So you might hear any of those terms today. All of those mean the same thing, and they are different from directed donation, which is where somebody has a very specific recipient in mind to donate to, like a friend or family member. For those of you who might be new to Zoom, both our speakers today are happy to take a few questions after their presentations. Towards the bottom of your screen, there's a Q&A button. If you press that, you'll be able to submit a question, and we'll take as many of those as we're able to do. You will also be able to see other people's questions, and there's a little thumbs up button. Sorry, my antivirus software has just popped up. Just bear with me 1 second. There's a little upvote button which basically prioritises that question, lets us know that you would like that question answered too. So please do use that facility. If you're on a phone or on a tablet, you might have to touch your screen to activate that Q&A button at the bottom of the screen. So thank you. So I'm now going to introduce Dr. Emma Massey. Emma is a health psychologist with a particular interest in research, education and care. And one of her interest areas is specifically around living donation, and in particular anonymous donation. Emma, I'll pass over to you to introduce yourself further. Thank you.
Thank you, Jan, for the introduction, and thank you for the invitation to present today during this webinar. I'm happy to share some of our research results on a study that we did in Rotterdam. I'm going to try and share my screen with you so that you can see my slides. And Jan, if this has not worked, then please let me know. So I'm just going to make this full screen. Okay. So I think this is going well. Okay, so I use the term unspecified donors. Obviously, Jan just explained that this is living donation to a stranger. So I'm going to talk about the perspective from the Netherlands. We are one of the countries, along with the UK, who has quite a flourishing anonymous donation program. So I'm going to start with the with the figures in the Netherlands. We started anonymous donation in 2000. So here you can see, I'm really sorry if you can hear the kids on the background, but anyway, I'm just going to continue. We started anonymous donation in the Netherlands in 2000. Unfortunately, it was only one in that block, so you can't actually see there between 2001 and 2002, but there was one in there. And so it was in the beginning very slow and just a handful of donors. But here you can see gradually over the years we've developed the program. This is the light blue bars. Over the years, and currently anonymous donors make up, depending on the year, between 7 and 12% of the living donor pool in Holland. And here you can see since 2008, so the previous figures are for Rotterdam only, and these are for the Dutch figures, for national figures. We actually, the whole country only started registering the anonymous donors in 2008, which is why we only have from that date national figures. And here you can see the same trend. You can see the length of the bars in total has been gradually increasing. This means that living donation has been gradually increasing over the years, and the proportion of anonymous donors is the light blue, the turquoise with the numbers in it. And you can see that we had a peak in all donations in 2016, and 2016 and 18 were also our peak years for the proportion of anonymous donors. Unfortunately, what this graph also shows is what we're seeing in a lot of countries is that living donation is actually reached a peak and is a little bit decreasing over the past few years, and there's a lot of speculation as to why that might be. I'm not going to go into that today, but it's an interesting fact. So I mentioned it just now, anonymous living donation varies, practices vary between centres within a country and widely between countries. And so it often occurs in countries where there's a very well-established living donation program, so it's a kind of extra on top of the well-established program between family members or partners or friends. So countries such as Canada, the UK, the Netherlands, the US, and to some extent Sweden have quite a flourishing anonymous program. But to some extent, whether you can donate your kidney to a stranger is a little bit of a postcode lottery. And what are the reasons for this variation? Well, there are lots of reasons. Ethical, for example, how a certain culture looks at living donation in general, whether there are objections, moral or ethical objections to living donation. Legal or political, you could say. So in 2012, there was an extensive legal analysis of living donation carried out by Leonie Lopp, and she highlighted that in some countries, you have to have an established relationship with the recipient, and countries such as Germany, Finland and Hungary have this requirement, which by definition means anonymous donation is excluded. Cultural differences determine, for example, not only how a culture looks at living donation, but also whether there's a preference or indeed how they look at deceased donations. So some Asian countries are less comfortable with deceased donation, which means they by default have a more flourishing living donation program. The role of religion and some psychological aspects. For example, in the early days of anonymous donation, there was some skepticism, there were lots of questions around motivation to donate a kidney to a complete stranger, and mental health of living donors. So both Hannah, who will give the second talk, and I have over the past years been focusing on particularly these last questions regarding motivation and mental health. So you can see this skepticism to some extent reflected in the titles of some early papers. So Living Anonymous Donation, Lunatic or Saint. Is this an offer we can't refuse? The challenge of anonymous donation, there was this feeling that there was some awkwardness surrounding it. And unfortunately, as perhaps some of you will have known or have experienced yourself, some resistance. A lot of donors report coming up against lots of barriers, not only in their own network, but also in the hospital, unfortunately. So this is the focus. So first wanted to just go through a little bit, what do we know to date about mental health amongst anonymous or unspecified or non-directed donors? So there have been some studies looking at quality of life or mental health outcomes amongst a cohort of all donors. And these typically show that there's a return to baseline levels, so a return to your pre-donation level of mental health between 3 to 12 months after donation, and that the level of mental health is comparable to the general population. However, these studies have been done in all donors, whereby the proportion of anonymous donors in these larger studies is relatively low. Often these studies have followed donors up to 12 months, which is of course a quite limited follow-up. And there are also quite a lot of studies that only look back after donation, but they didn't do any measurements before donation. So we call this retrospective research rather than prospective, which means asking questions before donation and then following donors over time, preferably longer than 12 months. So, in addition, few studies specifically look at just anonymous donors, those as a target group. So these limitations of the research were the reason why we carried out the MEGA study, which is the Dutch acronym for mental health after anonymous donation. And we set out to look at various areas of mental health. So we wanted to look at psychological well-being, so not just the negative side of mental health, but also the positive side, which I'll explain a little bit later. Also the psychological symptoms, and you can think about things like symptoms of depression or anxiety. And we also wanted to know whether people who had donated their kidney to a stranger, what kind of level of actual official diagnosis we could detect in this group after donation, and to look at what kind of diagnoses might they have, because symptoms is not the same as a diagnosis. We also did a little bit of qualitative work in this study, where we looked at in an interview setting, so asking donors in their own words. We looked at their personality characteristics, major life events. We explored decisions to donate, the expectations and motivations around their donation, their emotional experience of donation, what their thoughts were about anonymity, remaining anonymous, their mental health, and the relationship between donation and mental health. These qualitative outcomes I'm not going to go into today because we're just still analysing this data. So what did we actually do in this study? We invited all our anonymous donors that had ever donated in our centre, so it's a single centre just in Rotterdam. So we invited them all back for an interview and to fill out some questionnaires. They were by definition all adults, of course. So interview and a questionnaire, I already said that, and this was carried out between the beginning of 2018 right up to August 2019, luckily before the corona bomb exploded. So I already mentioned we asked them to complete some questionnaires. Here you can see what those questionnaires were. So the mental health continuum explores the positive side of mental health. The psychological complaints was measured using the symptoms checklist. And for the psychiatric diagnosis, we did a kind of two-step procedure whereby we did a kind of general screening with all the participants, and if anything was flagged up on this mini screen, then we had a psychologist come in. We had a psychologist on standby, and they came in and did an in-depth diagnostic interview. So in the end, we identified 142 donors who had donated their kidney in our centre between 2000 and 2016. 136 were eligible to participate, the difference being those who had died in the intervening period, and 114 consented to participate. So it's really high participation rate for this kind of quite intense study, where they all had to come back to the hospital and participate, make the time for the study. So I want to share some of our results. So now I can explain a little bit better what the positive well-being was and how we measured it. So here you can see on the left the concepts that we looked at. So emotional well-being consists of positive emotions, feeling of happiness, for example, and a feeling of life satisfaction. Social well-being is more the interaction with the environment, so feeling accepted, feeling like you've made a contribution and that you're integrated in a network. Psychological well-being refers to a kind of more internal sense of growth and acceptance and autonomy. So the other two columns you can see there are the mean scores for the donor group that we investigated, and to the right you can see the mean scores, the average scores in the general population. And what we see here is that the donors score significantly higher on 2 of these subscales out of the 3, and also on the total score. That's the small red stars indicate that our donors basically report higher well-being. That's the conclusion of this slide. So this was a really interesting finding that hasn't really been reflected in previous studies. Here we see the psychological symptoms. So I'll walk you through what you can see here. On the left, you can see the various kinds of symptoms you might experience. So general anxiety, phobias, depression, somatization, which means more physical expression of psychological pain. So you could think of tummy ache, headache, that kind of thing. Inadequacy in thought and action is actually more what you might know as sort of obsessive compulsive symptoms. Interpersonal sensitivity is problems with interactions in social environment. Hostility, I think, speaks for itself, aggressiveness, and sleep problems. And the final one, psychoneuroticism, is the total score. And what we can see here is the mean identifies what the donors scored. And you can see here the norm category column, and that's just basically what kind of average score would you expect in the general population. And what you can take from this slide is the average score in the donor group was comparable to an average score, so not elevated in the general population. So donors had a comparable level of complaints to those that you would find in the general population. But the data that I'm showing here was collected during the interview, so this is all after donation. What we also had was data from on-site symptoms from the pre-donation period. So during the screening, we'd used the same questionnaire. So we were able to compare pre-donation scores on symptoms with the score obtained in the interview. And we had this data for 98 of the donors. And when we compared those scores, we saw that on average there was no significant change, no significant increase or decrease between those 2 moments in time. Finally, the last little bit of the third question we wanted to look at was a more sort of official diagnosis. And we, from the screening interview, which is the mini screen here, you can see 53% had no indication for a diagnosis. And a screening interview is usually often, you get more false positives. So you can say this 53% is very accurate, that they don't have anything going on. There's no suggestion of a diagnosis. And we had 47%, there was this suggestion that there may be grounds for a diagnosis, but there's a lot of false positives in there as well, because the screening questionnaire, that's its job, it's to filter out those who have potential for whatever it is you're looking for. In the in-depth interview, which is the little arrow, we actually found 32% actually had a current or lifetime diagnosis on the things that we looked at. And we saw that a lot of these diagnoses were in the past, so it was 25% had a current diagnosis. And when you compare that to the general population in the Netherlands, it's about 42% of the entire population will have at some point in their life a psychiatric diagnosis. So 32% is at least under, so we could say it's comparable, but it is in effect under 10% lower than the general population. So what kind of diagnoses were we seeing here? I'm just going to move that little block up. So what I just want to flag up was these are the things that we found, the kinds of diagnoses. For example, quite a lot of depression, some anxiety, sort of a handful of different kinds of anxiety diagnoses, and post-traumatic stress disorder which is all of that was in the past, but there was definitely some prevalent current depression, and those were the highest two things, and some incidental findings, for example, psychosis or bulimia, just one donor each of those diagnoses. Interestingly, during the interview, we asked about, have you been treated by a psychiatrist or a psychologist now, and had you had that before donation? So this is after donation, reporting about before donation. And what we found here, which I think is quite a high number, is 40% reported, yes, I had been treated by a psychiatrist or a psychologist before donation, whereas currently 15% were in treatment, so not so much medication, but psychotherapy or talking or counselling. And here you can see 17% reported having a psychiatric hospital admission before donation. And here, unfortunately, we tried to sort of explore to what extent did we know this prior to donation. And unfortunately, the recording in the case notes before donation is not accurate enough to be able to compare this figure. But I suspect that we didn't know about a lot of these psychiatric admissions during the screening, because other earlier studies have reported there's a kind of underreporting before donation because people quite simply want to pass the screening. And looking at the last one is medication, so antidepressants, for example, and this was quite stable before and after. About 1/3 are on psychotropic medication. So to conclude, what can we say about this group? Well, first of all, there was a very high willingness to participate. This is quite typical of living donors who are often quite altruistic. That's not surprising, but very willing to contribute to science and to improve things for future donors. We felt there was also a quite high level of disclosure. This probably had to do with the fact that the anonymous donor coordinator was the person who was inviting them to do the interview. The high level of disclosure also suggests that they may have been underreporting pre-donation on some of these things, like psychiatric diagnosis or admissions, but this is not something that we can really substantiate with facts. It's a kind of feeling that we had from the findings. When we look at psychological symptoms, we see they remain stable pre and post donation. This is reassuring. And when we look at the symptoms and the level of psychiatric diagnosis, we see it's comparable with the general population. Interestingly, we found psychological well-being was higher than the average in the general population. The question is, of course, where does that come from? Is this because they've donated, or would they have already have had a higher sense of well-being? I'd be interested to hear your thoughts on that. And there's also a lot of information we also have that could potentially answer that question, which is more qualitative analysis, and we're working on that at the moment. So I hope to be able to share that with you another date, what kind of themes come out of that. When we look at the future, so lots of studies usually generate more questions than answers. This was a retrospective study to a large extent, although we did have some baseline data. So it was basically looking back on donation and what kind of influence that had on mental health. I think there is a need for long-term prospective studies, of which Bound is a really good example, which Hannah will share with you after this. One of the criticisms of any kind of study on anonymous donation is that we don't have a good comparator group. It's quite hard to devise a good comparator group, but I think large studies that involve all donors and have a good selection of, or at least a good volume of both kind of specified and unspecified, or family and anonymous donors, would at least be a start. And on a kind of higher level, I think, those of us who do work with anonymous donations do have a kind of responsibility, and I know that Give a Kidney are also very proactive in this, to try and remove barriers for anonymous donation in places where it's not possible yet, and findings such as these, studies such as these that Hannah and I present today, I think are really important to help remove barriers and any skepticism there may be about this kind of donation. So I want to just acknowledge the fact that actually my colleague, Vili Sauduma, did all the hard work, because she did all the interviews and provided all this amazing data that we could analyse, and the rest of the team there as well. So if there are any questions, I'm willing to take them now. I haven't looked at the Q&A, but I'm sure Jan will help me out with that.
Yes. Thank you so much, Emma. That really interesting and reassuring, I think, to see that data, because it's something we have talked about over the years a lot around well-being, people's well-being and the impact of donation in what is, of course, a very emotional process. But yeah, wonderful to see that the positives that actually come from donation for some people, and that alignment with the general population and what you would expect in the general population. So given that, we've got a really good question from Sally, and this has come up before, so it probably won't surprise you, and we've talked about this a lot at Give a Kidney conferences over the years. So in the UK, I'm not sure if it's the same in the Netherlands, you might elaborate, but as part of the assessment process, the potential donor, if they're a non-directed donor, has to see a mental health professional, a psychologist or a psychiatrist. So given that, I'd be interested to know if that's the same in the Netherlands. But do you think that should remain a requirement for the assessment of non-directed donors? Do you think that's
Yeah, so it is the same generally. Who does it and at what point, and the procedure, it does tend to vary. This is also part of my clinical work, so I do see in our centre all the anonymous donors, and the family donors I see on indication. So when there's some indication that there's some kind of issues with the family, or for example, if the family don't really want the donor to proceed, or if there's some kind of psychological reason in their history, in their case notes, then I will see family donors as well. I really think that the rest of the team are really good at kind of filtering out those who need to come to the psychologist among the family donors, and I think that could be, and perhaps should be, the strategy that we use with all donors regardless. So I agree that there is no grounds anymore. There is lots of evidence that we don't need to be skeptical, and not all anonymous donors need to go to the psychiatrist or the psychologist. So I agree with that, and but there is this kind of remaining reluctance, and it's also kind of a history. It's like, this is how we do it, and it's hard to change that. It's a little bit sort of become part of the fabric of the program, that's the way it's done. But I do think that it's important to have a psychologist on the team, or at least a link with mental health services, that for anybody who needs an extra screening or support through the process, that's offered to everybody regardless of the type of donor.
Thank you, Emma. I know it's a part of the process that often potential donors are concerned about. So yeah, really.
Nobody wants to see the psychologist.
Nobody does. No, they don't. But often very, very pleasant, actually. They're there to protect people's mental health, aren't they? To make sure that they're as safe as possible.
Yeah, we're there to offer support in the end as well, but it is a little bit of a double role, which is sometimes hard to juggle. You're also there to screen and screen out. So offer support. You want people to be open, but you also are looking for reasons potentially that it might not be good for them to go ahead. So yeah, it's a tricky job actually.
Yeah, but they're to make sure they're as safe as they can be, to eliminate the risk if it's there.
Yeah.
So another couple of questions. Maybe this one's quite quick to answer. Do you know that you talked about the people who you were not able to interview from the identified cohort was because they're deceased? Do you know if any of those deceased were related to the donation? Were you able to identify that?
Yeah, no, none of them were related to donation at all. But people, get older with age, and obviously some of the donors were older when they donated, and this was like 16 years later. So people develop cardiovascular disease or cancers and things like that. Just the usual suspects that you would find. So there was no donation related deaths. No.
Thank you. Again, reassuring. And a question from Joe. Thank you, Joe, who was asking about, and I don't know whether your study would have brought this up, but obviously you identified that people had returned to their kind of mental health baseline 3 to 12 months after donation. Is there any research, or did your study look at the immediate period after donation? I think we anecdotally hear that can be quite a tough period for people after they've gone through that kind of build up, lots of adrenaline, and then sometimes can hit a bit of a low when after donation, when things kind of settle again.
Yeah, there's a kind of emotional release after donation, probably. I mean, I haven't donated a kidney myself, so everybody watching knows this better than myself. You work towards it, and then it's a kind of a climax, and then afterwards you've achieved your goal, and that's typical with these big goals. And then afterwards it's a bit like, okay, and what's next? But then of course when you've donated a kidney, you've also got the physical aspects. So I think the first year is the most crucial and the most difficult, but it really depends on the person how quickly you are back to normal or back to your pre-donation level. And some people do struggle more than others, anonymous or not. But I think those who go in with lower levels of fitness, lower levels of, or higher levels of stress, that those are the things that that determine that recovery period, and also sort of medical complications that we know are quite determining for how that period will go. So if a donor has some kind of complication, then it often affects their mental recovery as well.
Thank you, Emma. We'll probably have to move on quite quickly, but just a quick question from Sally, and it's a question that concerns a lot of people as well. We get lots of questions around what other kind of particular, in the mental health assessment, what might make you turn somebody down for donation? What are you particularly looking for?
I'm looking at, it's a puzzle, and I haven't turned down many donors, I have to say, because I think if there are sort of more troubled donors, or donors with more going on in their lives than just donation, then we tend to just offer support rather than turning them down. But people, I've turned down donors with active mental health issues like schizophrenia, or people who are recovering from traumatic events with ongoing current PTSS, for example. So those are the quite hardcore mental health issues that are ongoing, for which somebody is being treated. But our kind of ethos there is we don't want to affect that recovery period from their mental health issues. So we don't, if they have kind of an increasing line of recovery, we don't want to affect that line. So those people, a handful of cases we've said sort of, particularly with anonymous donation, that's the great thing. We can say, work on yourself, come back when it's a better time for you, because you can donate this year, but you can also donate in 5 years' time, and we would still be really happy with that. So.
Thank you. Thanks, Emma. I think we're probably going to draw to a close now. I'm aware there are a couple more questions. If anybody has a burning question for Emma that we haven't managed to get to, they're interesting questions, do let us know after the session, and we will ask Emma to respond to that via email. She's agreed to do that. So thank you, Emma, for your time this morning and for being with us. Really, really interesting. So thank you. And I'm now going to just hand over to Hannah Maple. Again, thanks for being with us, Hannah. Hannah's a transplant and general surgeon at Guy's Hospital in London, and is also a clinical lecturer with particular interest in health psychology as it applies to transplantation. So Hannah's going to talk to us about the Bound study, which I suspect many of you watching, listening today might have been involved in some way. So I'm going to pass over to Hannah to give us an update on that. Thank you, Hannah.
Thank you, Jan. Very kind. Let me just share my screen with you. So yeah, as Jan said, I'm a transplant surgeon based at Guy's. And Bound is basically my baby, really. I'll give you a little bit of a background in a moment, but I just wanted to say that I'm giving this talk on behalf of a much bigger team. At the moment, myself and Professor Mahmood at Guy's are the sort of the main people running this, but we do have an army of people who are working behind the scenes. And so this is really a group effort. And I would want to acknowledge those people right from the very beginning, really. So what I thought I'd talk about was basically where it all began, what we were aiming to do with this project, and then give you an update, as well as some results, but also talk about some of the recruitment and some of the challenges that we've had along the way, before drawing some conclusions at the end. So where it all began, basically this all started when I embarked on my PhD. So I had a little break out of clinical training, and I decided at the end of 2011 that I would pursue a higher degree looking at psychosocial outcomes in living donors. And this graph basically gives you an idea of what was happening in the UK on the altruistic donor side. And basically there was this big upsurge in altruistic donations, and we thought at the time that it would make perfect sense for us to incorporate this into the study that I was running at the time. So we published this paper back in 2014, which is a retrospective analysis of all the people who donated a kidney anonymously. At that point, there was 148 people who we sent our questionnaire to. And then we recruited a sample of people who donated to somebody that they knew, who donated at Guy's, and we wanted to perform a comparison between the two groups. So the key findings from that study was that there is this huge variation in donor rates across the UK, with 45% of donations performed either in Plymouth, Portsmouth, or at Guy's. And we weren't 100% sure why this variation existed. The other thing we looked at, similar to what Emma's already discussed, is we looked at all of these different psychosocial outcomes because we wanted to see whether or not there were any differences between the two groups. This is a very busy slide with lots of numbers on, but basically, if I draw your attention to this end column, none of these values are statistically significant. So basically what we demonstrated was that after donation, there was no difference in any of these factors between people who donated to somebody that they knew and people who donated anonymously. So the question that kind of stemmed from that was, well, actually, one of the arguments against altruistic kidney donation is that the donor can't see the benefit in the recipient. So by the same logic, you would expect almost the specified donor group to do better because they see the outcome. However, we didn't show this. So number one question is, well, why does that not exist? But on a more philosophical level, what does this tell us about living donation generally? So then the cogs kind of started turning. And then we started looking at what other people had found. And there were a few sort of, as Emma's already mentioned, some papers that were published and lots of chat in the transplant community about altruistic donation. Somebody presented an abstract at the British Transplant Society meeting reporting quite high rates of dropout. I mean, I must say, they didn't really compare the dropout rate of specified donors. So, you know, that was one of the main problems with their project. But, you know, there were people reporting that the dropout rate was high. There was a lot of mixed feelings amongst transplant professionals about this practice. And also feedback from yourselves in terms of, actually, some of this negativity was coming across as part of the workup process. And then we were wondering, well, actually, are we as transplant professionals a barrier to people proceeding with donation? So the baby was born and the baby was Bound. So Bound is basically, it was a 5-year study which was funded by the National Institute for Health Research. That has now become a 6-year study for reasons that I will talk about in a moment. so we were meant to finish in March of this year. We're now on paper finishing in March next year. However, because of COVID, we're actually going to request another 6 months, just because there's been delays, which I'll talk about in a moment. But this is a prospective study looking at before and after donation. It's across every single kidney transplant centre in the UK, and also adopts a mixed methods approach, so has a mixture of questionnaire and sort of numerical data, but also lots of interview data and qualitative analysis as well. And the sample of people we've recruited has included donors, but also people who've entered the process and then not donated, which is a unique thing about this study. But we've also done some work on transplant professionals as well, trying to sort of tease out some of the issues that we'd identified as part of the practice previously. So the aims of the study, the transplant professional bit is really looking at, are there variations of attitudes? If they are, what are they? And do these pose a barrier to donation? For the donors, we're interested in, are there differences between the two groups of donor before donation and afterwards? What's the recovery like? But also, what happens to those people who don't donate? Psychologically, we don't know much about this group. So we thought that this was a really good opportunity to look at both people who were donating anonymously and to someone they knew, as to what the outcomes are for those who, for one reason or another, either they decide they don't want to proceed, or we say no to them. And then finally, we're looking at the economics. So one of the main things that people used to come up to me and say was like, well, all these people turn up and they say they want to be an altruistic kidney donor, but they don't proceed, and that's costing us money and it's costing us time. So actually we thought, well, we need to really get some proper numbers as to what the costs and benefits of this practice are. And also, can we answer the question of what is an altruistic donor kidney worth, both on its own, but also when you start thinking about things like the sharing scheme. And I think this is going to be one of the really, really interesting landmark results from our study. So just to give you an idea of how complicated this is the basic flow chart for Bound, which I don't expect you really to want to look at too much, because it still makes my head slightly explode. So I thought I'd simplify it. So what we did was we started off with some focus groups. We've got some transplant professionals and some previous donors in a room and chatted about some of the issues. And then we divided the study into the 3 groups that I've already mentioned. So the professionals group, there was a cohort who had semi-structured interviews, and then we distributed a questionnaire to the whole of the UK. Similarly with donors, we divided them up into people who'd been interviewed and also people who had completed a questionnaire as part of the prospective study. And we sampled our group of interviewees from people who'd participated in the questionnaire study. And both of these groups are divided into people who either have donated or those people who haven't. And then finally is the economic bit, which is related to the questionnaire data that the donors are filling in for us. So how are we getting on? So we're currently into year 6. We've recruited over 1,000 participants, which makes this by far the biggest study of this type globally, looking at this particular topic. There's been a few challenges. So basically we got our research money in 2014 thinking that the numbers would continue to climb. So we forecast the sample size of the study based on the fact that the rates of donation were going up quite quickly. And then we saw this slight slump, which obviously was a bit of a challenge. We think that some of this was as a result of the sharing scheme, and that actually there were some limitations because of the fact that this happens 4 times a year. And what it meant in terms of practicalities was that we had lots of activity at very fixed time points and in a very short period of time. And actually keeping up with it, all 23 transplant centres was actually quite challenging. But you know what, the benefit of all of this is that we've transplanted more people, and that's kind of what we're in this game for anyway. So we've tried not to dwell on that. We've tried to work out ways of navigating the sharing scheme as best as we can. In terms of specified donors, I think when I re-inherited the study, so I disappeared off and did some surgical training for a bit, and then came back and took back control of the study in October 2018. And the real deficit was in our specified donors, so people who donate to somebody that they knew. And I think there was basically a slight lack of awareness. We'd maybe taken our eye off the ball slightly in terms of recruiting these people to the study. But we managed to overcome that. I must acknowledge Anna Taylor, who's our recently departed trial manager, who really worked incredibly hard to turn this around. The other challenge that we had was that everything actually took a lot longer than we thought it was going to take. And that's because things tend to. And I think, especially with COVID, which I'll talk about in a sec, the analysis has taken a lot longer. And, that's just a learning point for us, really. So literally, just as we thought we'd turned a corner, we'd recruited everybody that we wanted, we were skipping down the corridor thinking we were back on track. 2020 happened, and I think this is probably my most commonly used emoji for the year. So basically what happened was that as I'm sure you're all aware, the transplant programs across most of the UK ground to a very quick halt in March, and living donor programs in pretty much every centre just completely stopped. And as a result of COVID, they've been very slow to restart for understandable reasons. The matching run for July was suspended, so we had a lot of donors who were going into that, and then they couldn't. So everything's kind of been shifted into the autumn with the October matching run. So this gives you a rough idea of our activity. So we were skipping down the corridor at this stage, and then obviously this happened, which was not planned, but it is what it is, and we're optimists and pragmatists, and we just worked with it, really. So I'll talk a little bit more about where we're at in terms of recruitment in a moment, but I thought I'd just talk about some of the results that we've had so far. I must say that a lot of the analyses are ongoing. I basically had to abandon all my research time to go off and be redeployed to intensive care. So again, that's contributed to the analysis slowing down a little bit as well. But what I'll give you is a broad overview of what we've found so far. I can't give you specifics because obviously we're waiting for some of this data to be fully analysed and then also published as well. So what can I tell you about transplant professionals? Okay, so from the questionnaire study, we wanted to look at mainly people's views, their attitudes, and also their experiences, how these differed amongst different members of the transplant team, and also to see whether there were differences in attitudes and so on between the centres who were considered high volume and those centres that were considered low volume. So we received responses from 153 transplant professionals, and every single UK kidney transplant centre was represented. And we had a really good mix of people from across the different centres. And the take-home messages are, I mean, understandably, transplant professionals are very comfortable with deceased donation. And actually, most people are fairly comfortable with living donation to somebody that they know. But as you can see, there are significantly fewer numbers who are willing to consider them, people who would definitely want to or would definitely consider donating anonymously. And by far, the majority of people were unsure. And what this is telling me is that actually it's not the operation that's the issue. It's the fact that there is still a little bit of uncertainty, maybe about the merits of altruistic donation. And that's something that we're hoping to explore in a little bit more, in a bit more detail. People's experiences with altruistic donors are generally very positive. Most people were comfortable with the concept and felt that people had honourable motives. More negative views included some people thought that anonymous donors required more time investment, and there's this persistent issue about higher dropout rate. People felt that they would benefit from extra training and that possibly more resources would be helpful in investing into the programme. And then there was this issue of age. I'm going to park this just temporarily because it came up in some of the interviews as well, and it's something that we can talk about in a little moment. In terms of the views of the different categories of transplant professional, we're still looking at this in a bit more detail, and we're trying to look specifically at the ideas of support and acceptance and looking at what those factors correlate with. And again, centre variation we're looking at as well. I'll tease you and tell you that there are some early indications to show that there is a difference, but you're going to have to watch this space for me to tell you where the difference lies. So moving on to the interview study. So this analysis was performed by Mira, who is a postgraduate health psychology student from King's, who is absolutely fantastic and has done a huge amount of work and a very, very good job at looking at this data. So we interviewed 60 different transplant professionals from 3 high and 3 low volume centres. And the take-home messages really are that the interviews broadly support what we found in the questionnaires, but they obviously, interview data gives you a lot more depth that you don't get necessarily from numbers. So the provisional analysis, which Mira has literally just finished, has provided at the moment these broad themes, which are related to the ethics of the practice, the relationship between donors and recipients, and interestingly, as Emma's sort of already mentioned, how this fits in with living donation generally and attitudes towards directed donation. That has come up quite a bit. And then there's other things like managing expectations and stereotypes. And actually that it seems to be that there's a lot of sort of internal conflict within the transplant community about this particular practice. Not for any sort of bad reasons. I think it's just that we like evidence and we like data. And it might be that there's just gaps in the knowledge and gaps in the data, which if those are filled would help people be more reassured. The ongoing concerns do include motivations to donate, regret, and also psychological outcomes. But interestingly, one of the things that's come up is actually, do our directed donors actually need more psychological input? Is this something that we need to do generally better? And then there's this issue with age, which does overlap with the questionnaire, and it's not really an issue with older people wanting to donate. It's when younger people want to donate. In particular, it's the 18 to 25 group. And my feeling is that, I mean, this is something that I get asked about all the time. Every single time I talk about this topic at a transplant meeting or amongst my colleagues, this is the thing that people ask me about. And I personally feel we need the evidence from Bound, and then we need to sit down in a room together and come up with a uniform approach to this, and sort of thrash out what the issues are. But the good news is that Bound is hopefully going to address a lot of these issues, because it's going to hopefully provide the data that the transplant community needs on all of the things that they're still worried about to help support the programme. So donors, let's talk about the interview study first, because that's almost finished. So we wanted to look at what people's experiences of the assessment process was, what the experiences were like for people who did and didn't donate, what the psychological needs were and how we can potentially address them, and also what we as transplant people can learn about the process and how can we make that process better. So this included 15 people who had donated, and then 11 who had been withdrawn by one of the transplant teams, and then 9 people who had decided to self-withdraw from the process. Again, Mira did a fantastic job of analysing this data and identified 6 major themes, which included looking at maximising and sharing benefit, this internal monologue of risk versus motivation, support from everyone, be that family, friends, employer, the transplant team. The concept of self-actualization, which is, I believe, it's realization of your own potential, or your sort of self-realization and finding meaning in the whole act. The idea of becoming a patient, and then also talking about relationship with the transplant team. And the take-home messages from what I can share with you at the moment is that most people enter the process with a similar level of commitment. And those that don't donate do express a degree of dissatisfaction and sort of lingering emotional consequences, so feelings of regret or upset that they were unable to see the process through. And some of this appears to be linked to a lack of follow-up on our side. And we're looking at the questionnaire data will help us provide a bit more evidence, either in support or denial of this particular claim, so that we can marry the two studies together and see how many people have a similar feeling. And the other thing is really that managing expectations is really important. And it may be that we need to sort of set out at the very beginning that, you know, there are 3 possible outcomes. One is that you donate, and then you might not, and that might be because you decide not to, or because we find something. And maybe managing expectations is something we need to work a little bit more on. So in terms of the questionnaire study, we literally recruited our last patient the week before lockdown happened in March. So massive sigh of relief on our part. This is where we're at in terms of numbers. So on the non-directed, altruistic, unspecified side, we've recruited 163 people, which is 118% of our target. And then on the specified side, we've got 197 people in this part of the study. We wanted a few more just because we like to account for people who drop out or people who are lost to follow-up. So there are a few more that we're waiting to donate. So yeah, so we have a group of people who are basically ready to go, and that's one of the reasons why we've extended the studies to try and get these donors in. We know that the October matching run will mean that most people as part of that will either donate in December or January, and we wanted at least a 3-month follow-up period after that. But obviously the knock-on effect of COVID and all the other things that we've had going on is that the analysis has been delayed, but we're also very aware of the fact that we are collecting psychological outcome data, and this has been a very stressful and very testing time for a lot of people. So we will have to divide our analysis, or at least account for COVID as part of our analysis, because it might be that we find a huge amount of psychological morbidity in people who've donated and been followed up this year, which we're not seeing elsewhere. And that might be actually COVID and nothing to do with donation at all. And then obviously the economic analysis, that's linked to the questionnaire data, so that will follow in due course. So what are the headlines so far? Well, it would appear that centre variation does still exist. There are no significant differences in age, gender or ethnicity between the two groups of donors. We found that altruistic donors appear to be more altruistic in other ways, so more likely to be on the organ donor register, give blood, give money to charity and do volunteer work. This whole idea of religion, we've clearly shown in the data I've looked at, about 500 people, I think this was an interim analysis I did about 18 months ago, showed that actually religion is not a factor at all. And actually the altruistic donor cohort appeared to be less religious than the other group. They're less likely to be married or have children, which fits with what we found in our retrospective study. And there does appear to be a bit of a time lag. We think that's probably due to the sharing scheme, and also possibly because of the delays in getting mental health assessment, which we know is still considered mandatory. And sometimes a lot of our donors I know at Guy's do wait a little while for that. What we do know, though, is that it's not related to centre volume. So it's not like if you're in a low volume centre that you're taking longer because people are more cautious or taking their time. That doesn't appear to be a thing. So in conclusion, it's been a challenge. It's been a bit of a roller coaster, but we are nearly there. As I've mentioned, there are some ongoing concerns about this practice within the transplant community, with a specific focus on the things that are listed there. On the donor side, we've still got a lot of work to do. Me in particular still has a lot of work to do. But as I've just mentioned, there are some things that are sort of starting to filter through, which do lay some of the myths to bed. There is lots more to come. Hopefully in a year's time, I'll be in a much better position to give you some proper numbers and some proper results. And I just wanted to say thank you to everybody who has participated in this. Interest. Your contribution is really much appreciated and very valuable. So thank you. And just to end on a bit of a high, I think when we think about this huge, enormous piece of work, what we're trying to get out of it at the end, well, I think the main things are that we're trying to get clarity and insight for everybody, yourselves and us. I think we'll be in a much better position to know what resources we need, and actually how we can use our resources to support people better. And also the final thing to say is that we are always looking for people to get involved. It might be that we come back to you in a year's time and say, actually, we found this. Can you give us a bit more insight as to why we've got these results? And also with writing some of the guidelines, which we plan to submit to both the BTS and NHS as a result of this study, some patient involvement would be great for that as well. So if you're interested, then please do let us know. Thank you very much. I'm very aware that I've probably run over, but there's a lot to pack in. I'm obviously happy to take your questions and happy for people to contact me by email or on Twitter, as you wish. So thank you very much.
Thank you so much, Hannah. Huge undertaking, and just masses of data, isn't there? But will be incredibly valuable in terms of the programme going forward, I think. And yeah, so much to say on it. Are you okay just for a couple of questions?
Yeah, of course.
Fine. Yeah. So one of them, really interesting question, and I'm sure subject of great debates at BTS, ethical symposiums and congress, but what's your view on how you feel the transplant community will respond to the evidence showing that in some instances they themselves might be a barrier to people donating, and their personal views coming into play there?
To be honest, I think they probably already know that it happens. One of the things interesting that we've been looking at with the interview data is that there is this ongoing monologue in most transplant professionals' heads that say, I know that this is a good thing to do. The person in front of me seems to know what they're doing, etc., etc. But I'm still not 100% certain that I can be as confident in allowing this person to donate as I can someone who's donated to someone that they know. And I think when you really drill down on it, I think it's because the data in support of the practice is just not quite there yet. And anecdotes are only worth so much. You know, we are surgeons, and it tends to be the surgeons who have the biggest issue, the biggest ethical issue. And as a surgeon myself, I can understand and relate to that because I'm the person who is putting knife to skin. I'm the person who, if something goes wrong, is accountable for that, ultimately accountable. We work as part of a team, but in the eyes of the UK law, at least, the buck stops with me. And I don't think anybody is intentionally difficult or nasty or cynical. It's just that actually we need to provide them with the evidence that says it's okay. And I think once we have that, if we show that, that will alleviate a lot of the concerns. And I think even in the time that we've been doing the study, I've noticed a shift in attitudes in people. And I think one of the clinchers has been when any of the NHS BT staff show a slide at the British Transplant Society meeting showing how much contribution altruistic donation has made to the Living Donor Programme. It is absolutely phenomenal. And that, I think, has been a turning point in the community in terms of people saying, actually, this is amazing. And what a wonderful thing that we are able to do. And our sharing scheme, as I'm sure Lisa Benham's already told you, in the UK, we do more than the rest of Europe combined. And that is amazing. And I think that's something we should be really, really proud of. And I hope that, excuse me, that Bound just basically supports that whole practice a little bit more, and just gives people the reassurance that kind of they've been looking for to support their gut feeling, which is probably that it's okay.
Yeah, thanks Hannah. And I echo that. I mean, certainly since my involvement with Give a Kidney, I think I've seen a real shift in the attitudes of transplant professionals at the conferences and congresses that I've attended. And I think what was once considered a little bit on the edge of most people's practice and comfort levels, because, you know, medical professionals sign up to the ethos of first do no harm, and this is an elective procedure that major surgery. So I think there was some discomfort. I think that's shifted hugely, not for everybody, but there's been huge progress, and absolutely the recognition of the contribution of non-directed donors to the numbers of transplants that are now made possible as a result of people stepping forward, I think is now widely recognised, and that's hugely positive. So, but yes, having the evidence to say, as we've heard from Emma as well, that actually this isn't harming, you know, for the most part, this is not harmful, and actually may, you know, give people a greater sense of well-being. And just to add, now there are two other collections of data that are going on through NHS Blood and Transplant that we've been very involved with, which is a donor reported outcome measure and a donor reported experience measure, which is looking at both directed and non-directed kidney donors, and asking them for their views on the outcomes, the health and wellbeing outcomes for them, but also the experience of donation for them. So we're collecting that now, or inviting all donors to take part in that. So that will be ongoing from now. Both of those studies are now live as well.
Yeah, we're going to be correlating that data with our data as well, because obviously we've got lots of different other questionnaires that are being asked, and we're going to look at that and see how closely they correlate with some of the stuff we've done as well. So yeah, that'll all kind of mesh together quite nicely, I think.
Thanks, Hannah. We are running over a little bit, but I'm assuming people are happy to continue. Obviously, do leave if you need to, anybody. There's a question around the feeling of the time requirement that might be greater for non-directed donors than for directed donors. I'm wondering what that's about. Is that because the medical workup is essentially the same apart from the mental health assessment? Is that the hold up?
I'm not quite sure where this comes from. I don't know whether it's a sort of subconscious bias that people think that altruistic donors are more needy or are more motivated. Because I mean, I don't know. I mean, you know, most patients are a very heterogeneous group of people. Some people ring up all the time. Some people don't ring up at all. I think it's just something that's been a bit of a hangover from the early days, I think. I don't know where exactly it comes from, but in terms of the time lag, what we've shown is that actually they don't take longer because it is exactly the same. But where there seems to be delays, it is in acquiring the mental health assessment. And that's because we don't have enough mental health people working alongside us. I mean, I know that we're very lucky in that we've got 2 health psychologists that work with us. We also have a psychiatrist, Al Santhouse, who again has a wealth of expertise. So it's maybe not much of an issue for us. But in other hospitals, you know, you have to refer to general psychology, you know, and that might take a bit longer. But, you know, we're collecting data from things like dropout rates. We've got sort of how people have progressed through the system, how accurate that data is. I'm not 100% sure. I'll have to look at it in a lot of detail. But hopefully we'll be able to kind of get a rough idea of how long it's taken people to complete the whole study. And I think what we'll probably find is that there is no difference between the 2 groups at all.
Thanks, Hannah. Yeah, maybe perception rather than fact. There's a comment from Sanjay here, Sanjay Sinha, who's a professional in the transplant community, saying he feels that the medical community, transplant community, needs to end its paternalistic, he said, attitude towards non-directed donors, and takes up the role of actually what it's about, which is making it as safe as possible for the person donating. And he's commenting, you know, about age, and in his centre that they're, you know, maybe happy for a 20-year-old to donate to an 18-year-old sibling, but there's more questions asked if it's a non-directed young donor. And so the age issue comes up again and again, doesn't it? It'd be interesting to hear.
Yeah, I think I'm on record somewhere of saying that we underestimate young people. I think you look at Greta. I mean, come on, she's how old, and she's completely changing the world. And you think this is a young person who definitely knows what she wants and how to go about it. You know, and you know, the issue of young people donating has come up in the sort of the directed donation world as well. You know, my argument always is, you know, if I was 18 and a parent, or even if I was 16 and a parent, you know, it would be very difficult for someone to stop me from donating or wanting me to donate a kidney to my child. But, you know, with my other sort of hat on, I do understand why some people get a little bit cautious about it. But again, I agree, it's about making it safe, and for people to understand what they're getting into. And I think the data that we can hopefully provide from Bound will help, again, reassure people that it's okay.
Yeah. And placing faith in the assessment process. That's what the assessment process is absolutely for, isn't it? To make sure it's as safe as possible for people to donate.
Yeah, and I think this also relates to, I think one of the questions that was posed to Emma, or one of the ones that came up, was about whether the mental health assessment should remain mandatory. I think looking at from what has been discussed as part of the BTS before, I think there's a feeling amongst the transplant professional community that, you know, as a surgeon, I have an end of the bed. I can have an inkling that something's not quite right, but I'm not a trained mental health professional. And I think the practice at the moment, in the absence of high quality data, which hopefully Bound will provide, in the absence of that data, I think it does provide a degree of reassurance to the transplant community that actually that they've made an okay assessment about this person, if you see what I mean. It just adds a bit more support. And there, you know, there is an argument that says, you know what, if we had one person, if we were to scrap the mental health assessment and one person slips through and then something horrible happens to them, they end their own life or something happens, that could potentially shut the whole program down. And that's not what we want. So what we need is a bridge between, you know, as the attitudes evolve into this being an acceptable practice, and you know, fewer people needing the reassurance from a mental health assessment. Whilst that is happening, I do feel like it does help provide reassurance to transplant people who are not mental health trained. And I think that's the main reason why it's part of the process, and that's because we want to be absolutely certain, not trying to put up a barrier, if you see what I mean.
Indeed. Thanks, Hannah. I think we'll probably finish there because we've overrun a little. There's a question about when you're planning to publish and how people can access those results. I think if it's okay to say, if you follow Give a Kidney's channels, sign up to our newsletter, we'll certainly pass that information on and pass any links out as soon as we're able to, if that's okay.
Yeah. We've said 2021 is going to be our year, so watch this space, and yeah, I'll try and share as much with you as I can as we go along.
And we've had an update from Bound at every annual Give a Kidney conference, certainly for the last few years, or when there's been data to share. So yeah, we'll be happy to invite Hannah and colleagues back to share the findings. So so we'll leave it there, I think. Thank you again to Hannah and to Emma very much for giving up your Saturday morning and for really, really fascinating insights into your studies. Very much appreciate you being with us. Thank you to everybody who's joined us today. I hope you found it interesting, enlightening. As I said before, if you've got any burning questions, do drop us an email at Give a Kidney and we'll try to get those answered for you. We're currently in the process of pulling together a programme of events for the new year, question and answer sessions, reporting, etc. So do look out for those on our website or social media channels. And with that, I'll just say thank you, have a good day and have a good weekend. Thank you.